This video is going to focus on the pre-hospital assessment and management of hyperkalemia. So hyperkalemia happens when there is too much potassium in the blood, specifically in the blood but outside of the cells. So we call this serum potassium levels. So when serum potassium levels are elevated above normal, this condition is called hyperkalemia. So what causes hyperkalemia? Well, either too much intake of potassium via the things that you eat, or the inability to get rid of enough potassium, such as a patient in renal failure. So why is this a big issue for us in the pre-hospital setting? It's not something that we see very often, and it's even less common that we have to actually treat this when it is present in the pre-hospital setting. But it can be detrimental. It can be life-threatening. It can be life-ending. So it is something that we need to be aware of. We need to know how to assess for it. We need to know what we're looking for, and we need to know the immediate management for hyperkalemia. So what's the big deal? The big deal for us has to do with the heart. High potassium levels affect how the heart works, and we will break that down a little bit more on Wednesday, but we're not going to get too in-depth. So let's think of it in real simple terms. In repolarization, potassium is leaving the cell, right? And that's with nodal and or non-nodal cells, both. Potassium, when we're repolarizing the heart, potassium is leaving. And the reason potassium is leaving the cell is because potassium is mainly found inside of the cells. It's the primary intracellular ion. There's very little potassium outside of the cell. So if you have a semi-permeable membrane and you've got holes drilled in this membrane, and I've got a whole bunch of whatever that is, we'll say it's potassium over here on this side, and just a very few on this side, when I open up these holes, open up these channels in this semi-permeable membrane, then potassium is going to move primarily from the area of higher concentration through that semi-permeable membrane to the area of lower concentration. This is called diffusion. We've talked about concentration gradients a lot, so we're not going to do any more on that. But I do want you to think, if I was to greatly increase the amount of potassium on this side to where I no longer have that huge difference, then when I open up those channels, do you think it's going to be as likely that we're going to have as significant of a shift from potassium inside of the cell to outside of the cell? Probably not. So that's where the first issue comes in. The first issue is during repolarization. The big issue comes during depolarization. So let's talk about a couple of things. We're not going to break down why the issue occurs in depolarization. Just trust me that it does. The things that we're looking for in hyperkalemia, to diagnose hyperkalemia in the pre-hospital setting, and I say diagnose, we can't actually diagnose without blood work, but in order to have a really good idea that this is what we're dealing with and make a treatment plan for that of hyperkalemia, the first thing we need is hyperacute T waves. And that means tall and peaked. So if you were to grab a T wave on the ECG by the top and literally pull it straight up, it looks like you pitched a tent, like you took a tarp and put a stick under it. All right, they're tall, peaked, tinted, T-E-N-T-E-D, P-wave, or T-waves, T-waves. So hyperacute T-waves, that's the first thing we're going to look for. The second thing that we need to have present before we can consider the treatment of hyperkalemia is a widened QRS complex. So I have to have a wide complex, and I have to have tall peaked T-waves before I can start treating hyperkalemia. The patient's heart muscle is not going to be able to function adequately in severe hyperkalemia. So a couple of things that we're going to do for treatment. First things first, IV fluid. IV fluid is going to be great. Why is IV fluid going to be great? Well, because it's going to start to dilute the potassium concentration outside of the cells, right? Because our issue here is the concentration of potassium from the inside of the cell to the outside of the cell. So if I can lessen the concentration by diluting this blood, essentially making those ions spread out, then the concentration gradient to an extent can be restored. So isotonic crystalloid solution is a great idea for the patient who is hyperkalemic. The first thing that we want to consider after that is going to be a calcium of some sort, meaning calcium gluconate or calcium chloride. It does not matter. You can do either one. So calcium does not affect potassium levels. What calcium does, though, is help to stabilize the heart tissue, and that's going to be our main goal. Our goal in the pre-hospital management is not to necessarily bring serum potassium levels down, because we don't have a good way of doing that in the pre-hospital setting. But we do have a few ways to help make sure this patient stays as stable as possible until we get to the hospital. So the administration of calcium is going to help to stabilize the myocardial tissue. The next drug that we may consider is going to be sodium bicarbonate. Sodium bicarbonate can help to reduce the serum potassium levels. It's not going to be a significant drop, and it's not going to be a really, really fast drop, but it can lessen the potassium levels a little bit. And basically what happens with sodium bicarb is it pushes hydrogen ions back into the cell, and in return, potassium levels, I said that backwards. it pulls hydrogen ions out of the cell and in return pushes potassium ions back into the cell. So therefore we're reducing the amount of potassium outside of the cell in a roundabout way with the administration of sodium bicarbonate. I hope that made sense. I know I said it wrong the first time. I am sorry. But in general, our treatment for hyperkalemia is going to be isotonic crystalloid solution, calcium of some sort, either calcium chloride or calcium gluconate. Remember, the calcium is to stabilize the heart tissue. It is not having a direct effect on the serum potassium levels. And then sodium bicarbonate. In the hospital, they're going to give glucose, and they're going to give insulin. We'll talk more about that in a few days, or in Wednesday when we meet. And they also may consider a drug called K-oxalate. And K-oxalate is kind of like a activated charcoal for potassium. It's a potassium binding solution that you drink, and you essentially poop this K-oxalate that has a lot of potassium bound to it out. So that is the generalized treatment in the pre-hospital setting for hyperkalemia.